Hi, this is Dr. Bhavin Jankaria, and today I'm going to speak about the radiology and MRI of focal bone lesions. This is a precursor talk to the approach talk that I am giving in person at the Nanavati MRI course, and everyone who's attending that course needs to go through this in advance so that they can appreciate the approach that I will be talking about. So I hope that you all see this, and I will circulate this to the organizers in a little while. And today is Wednesday. But even if you're not attending the course, it's a contained complete lecture in itself. So when we look at focal bone lesions, these are the modalities or these are the issues that we need to talk about. And the modalities that we work with are the ones listed here. When we do plane radiographs, they must be done in two planes at 90 degrees to each other so that we can appreciate the soft tissue, the lesion, the extent, all of that very well. Now, if the radiograph is normal, but the patient has pain and swelling, as in this 14-year-old with pain and swelling in the left gluteal region, but the x ray, even retrospectively, is normal, then we do an MR, and the MR shows a lesion centered in the left iliac bone with soft tissue on either side. And this is reasonably characteristic of Ewing sarcoma, which it turned out to be on biopsy. So, if the radiograph is normal but the patient has pain and swelling, we will do an MR. If the radiograph is abnormal, then we make an assessment of benign versus aggressive on the radiograph based upon zone of transition and periosteal reaction. The zone of transition is the transition point between normal and abnormal bone. And you can see here that this is a very sharp, narrow zone of transition telling us that this is benign in this aneurysmal bone cyst. Again, here we have a sclerotic rim, and I know that there's a Lodwig classification with multiple grades, but um, in reality, all that we need to do is talk about sharp and non sharp zones of transition. And here we can see a sclerotic rim. It's a cortex based lesion, and this is a chondromyxoid fibroma. Whereas here we have a wide zone of transition. This is an aggressive lesion. There's a path fracture here. And this could be osteomyelitis, it could be Ewing sarcoma. That's what it turned out to be. The same goes for periosteal reaction. If we get a thick buttressing appearance, then this is benign, as in this osteofibrous dysplasia. But if we get irregular periosteal reaction, as we see here, with a very diffuse permeative appearance, then this is an aggressive lesion, in this case suggestive of osteosarcoma. And here we have a sunray appearance, Codman triangle, findings that we don't normally see these days, but nevertheless, and in the presence of osteoid, highly suggestive of osteosarcoma. So again, very aggressive looking patterns of periosteal reaction. So if the radiograph is abnormal, we will make an assessment of benign versus aggressive and look for classic leave alone lesions that don't need anything further. So these are the leave alone lesions that we need to be able to instantly identify on the x-rays so that nothing further is done. At the most these days, because of the hyposcalia with radiographs, MRIs do get done, but even then the idea should be to leave alone these lesions. So that's a classic non-ossifying fibroma. This is a classic osteochondroma. These are basically to be left alone. But for the rest, we need to get an MRI done. So if it's not a leave alone lesion with an abnormal X-ray, or it's a normal X-ray, but we are anyway doing an MR because there is persistent pain and swelling, we'll do an MR. The MR protocol is important, and I'm using this patient who has this right iliac lesion. You see this irregular periosteal reaction. Clearly this is an aggressive lesion, and we would do a stir coronal a T1 coronal, a T2 sag. You can swap these depending upon the region. T1 and T2 axials are a must, and then you do a stir coronal for both the hips if it's a pelvis, but in other instances we might just do a whole limb. We will give contrast. When we give contrast, we must do a dynamic study and then process these, and then we do a post contrast in all three planes. It is important to do a whole bone or preferably a whole limb study, and that's because typically you get skip metastases usually in the same bone, and MR is quite accurate for picking up skip met. So here you have this patient with osteosarcoma, and here there's a skip met more superiorly. So if you were able to evaluate from joint above to joint below, you would pick up most of the skip mets. What we normally do is actually look at the entire lower limb from hip to ankle. If we're doing that, if we're doing upper limb, then it's usually the ipsilateral upper limb only. So a preliminary assessment of benign versus aggressive on the radiograph helps, because if it's really benign, we don't need to do the whole bone T1 and we can save some time. Why should you do a dynamic study? This patient came to us, pain in the wrist, diagnosed to have osteosarcoma. 2 biopsies negative. You can see extensive marrow edema. They thought this was a sclerotic lesion here. This is when the patient has developed some more new bone, but it's very thick periosteal reaction. Doesn't look aggressive at all on the radiograph. And so when we did the MR, I did a dynamic contrast and we found this focus. You see this area here, which is dark on the MR, was actually showing rapid uptake and washout. This was an osteosteoma, which I then went and ablated. So if you give gadolinium, it doesn't cost you anything to do a dynamic contrast sequence. And unlike 20 years ago when I first started talking about it, every MR machine today has the ability to do this. So please do a dynamic contrast study. So that's the scanning protocol. And this is what you need to do every time there is a focal bone or a focal soft tissue lesion. So now once we have the X-ray and the MR, that's when we try to come to a diagnosis. Age matters. Here is a 64-year-old with thigh pain, sclerotic lesion with irregular periosteal reaction here in the mid-femur. You can see the sclerosis and irregular periosteal reaction. There's a little bit of periosseous edema, and you can see the lesion on the T1. What do you think this is? Just give it a thought, right? You don't need to think about it. Secondary bone tumors are more common than primary bone tumors by a factor of 100 to 500 in patients above the age of 35. This eye biopsy turned out to be met. The PSA was 45, done after I'd done the biopsy, and then he had a prostatic mass, and this was just CA prostate. So one rule is that in any patient above the age of 35, before considering a primary bone tumor, unless there are specific findings, always think of Mets myeloma lymphoma first. Then reassess the biologic behavior and location and matrix. So location matters. Some tumors are only epiphyseal, some are only diaphyseal, etc. Here's your classic epiphyseal tumor, and it has a sclerotic rim. So it's a benign lesion, epiphyseal, T2 dark. This is a classic chondroblastoma with extensive marrow edema in the epiphysis and partly in the metaphysis. This is an metaphyseal lesion, T2 dark, mild marrow edema. It doesn't have a sclerotic rim, but it has a narrow zone of transition. So giant cell tumors don't usually have a sclerotic rim, and that's a way to differentiate them from, let's say, an aneurysmal bone cyst. And this is a classic lesion extending up to the articular surface. We have an expansile osteolytic lesion that's metaphyseal in a young patient with fluid levels. This is benign. You can see the narrow zone of transition here, and it's an aneurysmal bone cyst. Diaphyseal lesion, you see beveled edges here. You see that? One edge here and the second edge here. And we know that beveled edges are common with LCH. But here's another finding: marrow edema out of proportion to the lesion, and that's periosseous edema as well. And the moment you see that in a young patient, again, and plus you have a beveled edge, you think of Langerhans cell histiocytosis. So these are the epiphyseal tumors: epimetaphyseal, metaphyseal, and diaphyseal. Then you have location in the transverse plane: central medullary, juxtamedullary, cortical, juxtacortical. That's your classic central medullary lesion. You see this cartilage here in the proximal humerus, kind of a little cloudy appearance, and that's a classic enchondroma. Again, epimetaphyseal, this is a juxtamedullary lesion, that's a giant cell tumor. Cortical lesion, classic osteoid osteoma. You can see the nidus with central ossification and marked cortical thickening. And then here we have another cortical lesion, sclerotic rim, cartilage like enhancement here, and I'll talk about this later. But when you see what looks like a liver hemangioma with puddling of contrast, that's what cartilage looks like. Therefore, this is a cortical cartilage tumor. That's a chondromyxoid fibroma. And then this is a juxtacortical lesion, irregular periosteal reaction. You see this lesion, you see the periosteum lifted up. This is clearly an aggressive surface lesion, so it's a aggressive surface high-grade osteosarcoma. And then here you have this, very well-defined new bone formation in the distal femur. Lot of, T2 dark areas. This is all osteoid. The cortex is not involved. There's no intraosseous or marrow involvement. This is a parosteal osteosarcoma. So that's the list here of the tumors that would be central, juxtamedullary, cortical, and juxtacortical. Then there are some tumors that occur in some locations. I mean, we don't know why, but that's kind of there. So if you see a phalangeal lesion, it's almost always an enchondroma. If you see a humerus lesion and an immature skeleton, it's almost always a simple bone cyst. And here you see the fallen fragment sign here with a fracture. In an immature skeleton, if you see a anterior cortical lesion with cortical thickening, it's almost always an osteofibrous dysplasia. Then we look at the X-ray and MR and look at the matrix and see what is inside the lesion. So till now, what had we done? We started with characterizing benign versus aggressive. Then we said we'll do an MR. If it's aggressive, then you need to do a whole bone T1 or a whole limb T1, etc. And then we said maybe we can narrow down the differential by looking at the location in the longitudinal plane, then in the transverse plane, and is it like is it a tibial lesion or a humerus lesion, etc. But then when we can look at the lesions itself. So here we have a dark lesion, marrow change. There is a lot of new bone formation in the tibia. A new bone, aggressive, is osteosarcoma. Here we have a very cloudy appearance. So this is classic cartilage, narrow zone of transition in the phalanx, all put together. This is an enchondroma. Here again we have a rings and arcs appearance, which we also get with cartilage, but in this case it's irregular, broken. This is a chondrosarcoma. That's the osteochondroma we saw earlier as a leave-alone lesion. Remember, that will always have marrow contiguity with the underlying bone. This arises from the fibula. You can see the thin cartilage cap here, and that's pretty much what it is. Malignant transformation is not common in osteochondromas. Typically, if you see greater than 2 centimeters thickness, change on serial follow-up, and marked irregularity and wide zone of transition, that's when you would think of malignant transformation, like in this patient. So you can see the rings and arcs appearance with marked irregularity of the surface. Here is the rings and arcs appearance on MR. You see this lobulated T2 bright appearance with septae. This is classic cartilage on MR. And when we give contrast, we see this peripheral enhancement, the nodular puddling here, and then these non-enhancing areas represent myxoid change. And this is classic chondrosarcoma. Then you could have a cystic lesion. So you can see here the simple bone cyst. Here you have a lesion in the femur that shows a sclerotic rim, and here again we have a femoral lesion with a nice sclerotic rim. So we know these are all benign lesions, right? And here in fact we're seeing ground glass, which would tell us that we're dealing with fibrous dysplasia. But the MR also helps. So here we see just fluid. So that's a simple bone cyst. Here we see fat. So this is an intraosseous lipoma. And here we see a T2 dark area telling us that's fibrous tissue. So that's fibrous dysplasia. And we have a secondary ABC transformation because of this fluid level. And I'll show you this all over again, right? That's how you can marry the X-ray and the MR together to come to a diagnosis. Here's an 8-year-old boy who had a football injury, then they got the x-rays and, these focal non-ossifying fibromas were seen. The MR had been done initially just for the ligaments, and then these were T2 dark, and somehow the radiology report did not emphatically say that these are non-ossifying fibromas and nothing further needs to be done. I actually biopsied this because of the helicopter parents going completely berserk when somebody said that there are tumors within the tibia. But everything's dark. So T2 dark, stir dark. This is classic fibrous tissue and therefore non-ossifying fibroma. And this is the list of all those T2 intermediate dark lesions that you can see or you can have with focal bone lesions. Fluid levels. So you see fluid levels here in the proximal humerus and you'd say, oh great, I think this is an aneurysmal bone cyst. But you must look at the radiograph. You have a wide zone of transition, irregular periosteal reaction. Clearly this is aggressive. There is new bone formation, so it's osteoid, aggressive. Clearly it's an osteosarcoma, and the fluid levels would tell us this is a telangiectatic osteosarcoma. On the other hand, we have fluid levels all across, and here is the lesion, sharp sclerotic rim, narrow zone of transition. This is an aneurysmal bone cyst. Do not interpret an MRI without the radiograph. That's the rule. So fluid levels can be primary ABC, or you can have them in other benign tumors like chondroblastoma, osteoblastoma, GCT and fibrous dysplasia. Then you have fluid levels in malignant tumors. But remember, those malignant tumors will appear malignant, as with the humeral telangiectatic OGS I just showed. And then you can get them in clear cell chondrosarcomas and very rarely in metastatic disease. Then we have the group of trabeculated expansile lesions, and these are the 5 tumors that behave or present in this manner. Here's a fibular lesion. You can see here there is cortical thickening, but this is solid. Expansile lesion in the diaphysis, immature skeleton, that's an aneurysmal bone cyst. Here this is trabeculated expansile lesion with some cortical thickening, again looks benign. This is in the metaphysis, but this was a pediatric giant cell tumor. Your diagnosis would be aneurysmal bone cyst to begin with, and this is a thick sclerotic rim, and this was a desmoplastic fibroma. We also need to identify benign aggressive lesions. What do I mean by a benign aggressive lesion? Look at this 12-year-old girl who has this osteolytic lesion, sclerotic rim, little beveled edge, narrow zone of transition. This is a benign lesion. But on the MR, it's angry, right? There's a lot of marrow edema, periosseous edema. There's no cortical break or extraosseous extension, but there is a little cortical expansion here. Benign on X-ray, aggressive looking on MR. This turned out to be Langerhans cell histiocytosis on biopsy. So this group includes all of these lesions. But when you see a lesion that looks benign on X-ray but has a lot of marrow edema, and periosseous edema, but you won't see a soft tissue mass, right? Then it actually reduces the differential considerably. Here is an osteolytic lesion. It's epiphyseal with a sclerotic rim. So anyway, you know this is likely to be a chondroblastoma from location, but it also has this typical appearance of, marked marrow edema, so that looks aggressive on the MR, looks benign on the X-ray, and that's your classic chondroblastoma. Obviously, we should look for infection and mimics. Here is an osteolytic lesion. There is sclerosis, but it's not a sclerotic rim. There is a mildly thick periosteal reaction here. But you also see on the MR a large soft tissue component. It's T1 bright walls, which we normally get with infection. So this is highly suggestive of osteomyelitis, perhaps tuberculosis. And obviously, we're going to aspirate and biopsy this lesion. So once we've done all of this, we've looked at the X-rays, the MR, come to a differential or a short diagnosis. Unless it's a leave-alone lesion like a non-ossifying fibroma, lipoma, etc., we will do a biopsy. And the biopsy has to be done along the line of the expected surgical incision. The Lewis article still holds very good, though it is almost 17 or 18 years old now. It will tell you which path to use, but what I still do, and remember I've been doing this for 30 years now, is that I will call up the orthopedic surgeon or the orthopedic oncosurgeon and discuss the route with them, especially if it's not straightforward, and reconfirm how to do the biopsy. Now, this is what I'm going to be discussing in the second lecture. If you don't know what it is, don't give a diagnosis. Just say that the lesion is indeterminate. And I'll come back to this case later. Here's a patient, osteolytic sclerotic lesion. There's some periosteal reaction. The MR shows a classic cartilaginous lesion. There's no marrow edema of any significance. There are cortical breaks. There's extraosseous extension. And the radiologist, quite bright otherwise, called it osteomyelitis. So the orthopedic surgeon went ahead and, curated it, didn't really send anything for histopath, no organism was found. And once you've nailed something like this, guess what happened? The patient came back with, this appearance. See this classic enhancement that you get with cartilage, the classic lobulated appearance here. Eventually, the patient had to get an amputation or a hip disarticulation done for this tumor. Ideally, the report should have just said long segment aggressive lesion with cortical breaks and extraosseous spread needs further workup, instead of saying it is osteomyelitis, and not even saying that a biopsy is required or anything of that sort. It should have been done. For those of you who are interested in focal bone lesions, I run this site, bstneoplasms.com. And, it's all free. I put up a case once a month whenever I have the time, and it's all there. Plus, I have a bunch of cases up on YouTube where I have a channel and where you'll find this particular lecture as well. So today's lecture was basically to talk about the radiology and MR of focal bone lesions. You start with radiographs. If they are leave alone, then leave them alone. You should know what is a leave alone lesion. Else do an MR, and of course if the radiograph is normal but the patient is still symptomatic, do an MR, use the correct protocol. Interpret the X-ray and the MR together. Keep age in mind. The older the patient, the more likely it's Mets myeloma, lymphoma. If you don't know what it is, you see it, you should just know, right? If you have the experience and expertise, and if you have to think a lot about it, chances are you don't know what it is, then just say that it's indeterminate. So instead of saying in the report, I don't know what it is, you say that the etiology is indeterminate and needs further evaluation. And that's it. Leave it at that. If you know how to do these biopsies, do them with permission. Otherwise, just mention that a biopsy is required. And that pretty much takes care of it. Thank you so much for listening to me.